Adolescence is a time where there is high emotion and an important time when individual relationships are made. It is the age range of 10 to 19 years old. This time period is important for laying the foundations of good health, rapid physical growth, as well as cognitive growth. Autonomy is the state of being self-governed. Autonomy refers to the capacity of a person to make their life their own. It is often difficult to define within the metrics of the law, moral and political philosophy, as well as ethics. In psychiatry, personal autonomy is not well studied. The second year of life is a dominant time in the lifespan for autonomy to develop. In Erikson's theory, autonomy and shame play a developmental role around the age of 2 to 3 years old. This time in a child's life is when they learn law and order, but the issue surrounds whether we follow those rules or whether the rules master the ruler. In well-functioning societies, autonomy is encouraged and maintained throughout their lives. In Oljarczyk and Young, they discussed patient autonomy and the rights of these patients. When looking at a medical standpoint, they discuss non-maleficence, or better known as the do no harm. This is put in place to ensure that a patient isn't worse off after they receive treatment. Two examples of this is if a patient agrees to a complicated surgery, even against the surgeon's wishes, as well as end-of-life care, where there's physician-assisted suicide, and everything along those lines. The relationship between psychiatry and autonomy is not well known, but as we age, we develop greater personal autonomy. Autonomy is an optimal hallmark in development and human functioning. Mental illnesses, however, can impact one's autonomy. Mental disorders, in general, can give a poor life. An individual may not be able to connect with the environment around them. Often when patients have a greater connection to their environment, they see their lives as worth living, and they are more capable of commitment to their treatment plans. There are two main categories in autonomy according to Bergman et al. These are competence and authenticity. Competence is the ability to form a goal and intentions and to act effectively on them. This includes being able to weigh different options, select between the options, and plan how to achieve that goal. In individuals with a mental disorder, they might not be able to form these goals. Authenticity is how self relates to desire and commitments that motivate them to act upon their decisions. In compulsive disorders, they may feel that their disorder is forced upon them, and they conduct these rituals. Addiction is an example of this, where an individual may continue to use their addictive substance, even if they do not want to. Mental illnesses, however, can impact one's autonomy. In the case of obsessive-compulsive disorder, or OCD, one may spend most of their days focusing on compulsive rituals, making a job or going to school very difficult. In OCD, the compulsions can be so devotional that one may not even realize that they are partaking in them. Whereas in depression, one may have no motivation, which in turn means they don't have any visions for the future. In Kiang and Bhattacharya, they hypothesized that yearly increasing in autonomy is positively associated with yearly increasing in parent-child closeness. They measured four main categories in their study: autonomy, parent-child cohesion, depressive symptoms, and self-esteem. When researching autonomy, they utilized the psychological well-being scale, which consisted of 9 items on a 6-point scale in order to calculate the results. And in order to calculate the results, they did a reverse coding of negative items, then calculated the mean. Researching parent-child cohesion, they utilized the Family Adaptation and Cohesion Evaluation Scales, or better known as FACES, to inventory, which was used to measure parent-child cohesion. Mothers and fathers were rated separately, with each subscale containing 10 items. In order to measure the depressive symptoms, they used a 10-item Center for epidemiological studies depression scale, which assesses depressive symptoms within a previous week. And finally, in order to measure self-esteem, they use the 10-item Rosenberg self-esteem scale. The results of the study showed that autonomy is stable over the high school years, hovering just over the midpoint of their scale. A possible explanation for the lack of change includes the idea that autonomy develops before high school or the development of adolescents as they enter college-aged years, which was mentioned previously with Erikson's beliefs. Another explanation is that the growth in autonomy is not necessarily linear. However, it was found that there was substantial change within adolescents from year to year, which indicates that many were fluctuating in levels of autonomy. With this information, the authors believed that their youth seemed to cancel one another, eliminating the fact that there could be a linear growth. Parent-adolescent relationships are highly bidirectional in nature, with parental behaviors affecting adolescents' adjustment, and with adolescents' behaviors in turn eliciting parental practices. However, there is more to adolescent agency in the socialization process than simple reciprocity. Adolescents contribute actively to the quality and nature of parent-adolescent relationships by giving meaning to parental behaviors and by engaging in cognitive behavioral responses to parenting. These processes are discussed in the context of autonomy-relevant parenting, a dimension of parenting with pivotal importance for adolescents' psychosocial adjustment. We call for more research on the microprocesses involved in the adolescent's agency because such research can yield a deeper insight in adolescents' differential susceptibility to parenting, which depends on factors such as age, culture, and personality. It can also help explain the multi-finality involved in parenting, with controlling parenting relating to distinct developmental problems in different adolescents. Finally, such research has applied value because it can help identify adolescents most at risk for the consequences of adverse parenting, and because it can help inform prevention programs aimed at strengthening constructive parent-adolescent communication. In the study that was just explained by Sononens and Van Steenkiste, they looked at the relationships between parents and adolescents. In their study, they found benign appraisal involving the practices that ultimately benefit the child. It also plays a moderate role in association in the controlling practices and developmental outcomes. This article focuses mainly on the parental side of the relationship, rather than the parental behaviors being unidirectional relationship. Adolescents actively contribute to the parent-adolescent interactions, and they differ in ways that this is completed. So getting more into the medical side of things, in an article written by Bucky et al., they discussed how autonomy and treatment of asthma are tied together. Their study looked at 295 individuals with moderate to severe asthma who completed 2 surveys. 1, the navigating ability to, and 2, the inhaled corticosteroids knowledge questionnaire. There was a statistical significance between autonomy and comorbidities. The results of this study shows the differences in social economic opportunities as well as educational opportunities encountered by patients. In an article published by Pollock et al., they were looking at the optimal, which is optimizing performance through intrinsic motivation and intention for learning, theory of learning. It suggests that autonomy can improve learning of simple motor tasks. It was hypothesized that enhanced autonomy and external focus would improve first-try performance on medical tasks. They did this study by utilizing a 2x2 design with high school students. They then conducted tasks that enhanced or routinely altered autonomy. They looked at 133 high school students, where it showed that enhanced versus routine autonomy demonstrated no statistical significance in the tasks, which were chest compressions, depth, deviation, and the peg transfer panelized time. The results show that the first try performance was not significant difference between enhanced autonomy or external focus. This study shows that more research needs to be conducted in order for the significance to be found. Emotion dysregulation is a risk of processes for developmental psychopathology. In Zimmerman et al., they looked at 91 individuals at the age of 12 and observed the interaction with their mothers during a period of time that was standardized, where they elicited emotions and emotional regulation in relation to their autonomy. The adolescents' aggressiveness and anxiety were assessed along with DNA samples being collected. They took DNA samples to assess the 5-HTTLPR, which is a repeat polymorphic in the serotonin transporter gene. They found that there was an association between the rate of autonomy behaviors, attachment security, which was related to agreeableness rather than hostile autonomy. The individuals who carried the shortened version of this gene showed a more agreeable autonomy, and when they were insecurely attached, they often showed signs more aggressive. That being said, the study agrees that the gene attachment interaction in adolescents moderates a higher negative reactivity in response to the threat of their autonomy. In conclusion, medical autonomy in adolescents plays a crucial role in their daily lives. It could be altered by their mental or physical health. Their relationships can play a significant role in adolescents' autonomy. Genetics play a crucial role, in the fact that there is a genetic component to our autonomy shows that there is still a lot that needs to be learned when it comes to autonomy and developmental psychology. And here are my sources.